This is the In Focus podcast from The Hindu.
Hello and welcome to the Hindu's In Focus podcast. I'm Zubeda Hamid, your host for today. For nearly a month now, the country has been rocked by protests by medical professionals. Services at many hospitals stalled. At many others, healthcare staff wore black badges while working. And in Kolkata, the epicenter of the protests, doctors have now begun telemedicine services to help patients while they continue their protest. These agitations began after the horrific rape and murder of a trainee doctor at the RG Medical College and Hospital in Kolkata. The protesting healthcare workers are demanding, among other things, speedy justice for the victim, as well as a central law that protects healthcare workers and spaces. The Kolkata case, they point out, is not the first. There have been scores of incidents of violence against healthcare workers across the country, and the problem is escalating. What are the reasons behind violence in healthcare spaces in India? How many states have laws to protect healthcare professionals? And why is there no central law despite a 2019 draft bill? How can the government, the medical community, and other stakeholders help build trust in the medical system once again? We delve into these questions and more with Atmika Nair and Uma Gupta of the Association for Socially Applicable Research. Good evening and welcome to the Hindus in Focus podcast, Atmika and Uma.
Hi Zubeda, hi.
Hi.
Atmika and Uma, let's start with who was most affected by violence in a healthcare setting and where does such violence primarily take place? What has your research shown you? Atmika?
Yeah, hi. So, it's a little tough to comment on very clearly as we don't really have a single source data or a robust surveillance system telling us who is affected, how much and how many times and in what way and where it takes place. But the literature review that we've done and our own research and we also have our own new surveillance activity has revealed that female healthcare workers are the most commonly affected ones. And they're most likely to experience violence in high-stress departments like ICU and emergency during their evening and night shifts. So it's, again, keyword being healthcare workers and not just doctors. So that includes nurses, your administrative staff, or your helping staff. So here, that's really important to know that it includes all healthcare workers, the female healthcare workers.
Uma, would you say that this sort of violence takes place more in public sector hospitals compared to private hospitals?
We believe that it takes place in higher stress settings. It's a little difficult to compare two departments in a public or a private sector, but within the same kind of field, it's more seen in situations with high stress, high value to life as well. So ICUs and emergency departments are more prone to such incidents.
So, Zubeda, if I may,
yes.
I could just add to what what Uma had said. She's absolutely right. So we can't really say that, violence is more in public sector or more in private sector because the reasons for it are different. So, public sector, as most commonly you'd see overcrowding or lack of trust, but in private sector, it would be high cost or so there are multiple reasons to it. So it's not really comparable. So we can't really say that public sector faces a lot or private sector faces a lot. Going back and circling back to my first point where we don't have a single source of data and a surveillance system yet in the country that records violent incidents in healthcare settings.
One of the demands from doctors following the brutal Kolkata rape and murder, and also I believe last year after the Vandana Das case, has been a central legislation. Could you talk to us about current laws that exist to protect healthcare workers? We know that Kerala and Karnataka have recently executed very stringent laws, but what about the rest of the states? And what has happened to the Healthcare Service Personnel and Clinical Establishments Bill of 2019?
I think Uma would be like a really good person to answer this. So Uma, like, go ahead. Yeah.
Thank you. There are actually various success stories from across the world where countries have enacted legislation and international law has also tried to address this issue. International humanitarian law, for example, protects healthcare facilities, workers, as well as the wounded and the sick during all conflicts. Countries like US, UK, and Australia have very strict regulations to ensure occupational safety for healthcare professionals. Nepal has had a dedicated law to protect healthcare workers since 2009, and countries like China and Taiwan have central health regulation laws that outline safety measures for and penalties for anybody who does disobey these laws. So we have a lot of stories from outside as well. And in India, we have about 21 states with different kinds of laws and different provisions and penalties. Kerala has been the epitome of these acts because now it has a very expanded scope, includes paramedical workers, students, ambulance drivers, and other stuff that was never included before. They've also tried to increase the penalties. All of this has happened after, as a response to the murder of a young house surgeon that occurred a couple of months ago. But on the national level, even though a bill was introduced in 2019, it was later redacted. There were a lot of reasons cited, most important of which were that health is a state subject and this law might end up encroaching the state jurisdiction. And such laws might set precedents for other professionals asking for similar laws for protection. And the fact that an amendment was posed to Epidemics Diseases Act and it should have sufficed. But the loophole here was that it was meant to be applicable only during the pandemic and it provided some relief during the pandemic and nothing after.
The IMA has again today, I think, written to the Union Health Minister asking for the central law to be brought in. Do you think that's a valid demand, and do you think that a central law would help in terms of better protection and implementation for the entire country rather than state-based laws? I mean, it could be done under the concurrent list, correct?
So I'd like to take this one. As Umar rightly said, that 21 states have acts that protect healthcare personnel and settings, but they're all variable in stringency and cognizance. So, to put it in very plain terms, for say a very similar crime, there are very different punishments across states. So it doesn't make sense. So we want uniformity. We want cognizant at the highest level for any violence that happens in healthcare settings, and that is only going to happen if there is a central bill. So that's where pushing for a central bill is very important. So even if we do have 21 state acts with like present at the moment, and even though states are making effort to expand its scope, so as Uma rightly said, like Kerala is it's become an example. It's at an example where they've increased the stringency of their act. They've increased the scope by covering all healthcare workers, which it wasn't doing before. Even if that is happening, evidence has suggested that after multiple RTIs have filed that we had a chance to look into, which has suggested that even when these state acts are in place, the number of convictions, the number of FIRs registered are abysmally low. So we do need cognizance for this particular crime or violence at the central level, and that can only happen when there is a very strong bill at the center.
So the laws are there, but the implementation in terms of booking cases and actual convictions is very low. Okay.
Yeah.
Moving on, let's talk a little bit about the whys. Many have said that violence against doctors and healthcare professionals is a symptom And the disease seems to be, as you mentioned a little bit during your first answer, the lack of trust in healthcare services, lack of communication, perhaps, expectations not being met. Then there are cost factors, the overcrowding factor, emotions running high. What are your views on this?
I think I'll go first and then Uma can add because she's almost, I mean, she's on her way to publish a paper on this. But so so the health expenditure usually ranges from about like 0.47 to 1.86 in like as from the national GDP across like South Asian countries. That includes India. So the lack of the required investment leads to limited workforce, adversely impacting healthcare delivery that reduces ultimately patient trust that I said before in the healthcare system and also the health workers. And in extreme cases, there has been evidence which says that a low budgeting and low financing can lead to violence. So a chronic systemic constraints will certainly like increase the frequency of such violence if it continues and nothing is really done about it. So this is obviously the matter of the public sector. The distress in private sector looks very different. So obviously private sector it works on a capitalist phenomenon. So the distress there is high cost, maybe low quality, or general dissatisfaction with the service. So the reasons are like really different, and so somewhere when we kind of look at causes as researchers ourselves, it's very important that we include everybody who's involved. So it's when we look at the reason, it's not to blame any one party or it's not to blame any one person, but when you kind of dig deeper into the reasons, you see that it's a system issue, it's a systemic issue, and it is not a person issue, both at the victim as well as the perpetrator side.
Uma, could you respond?
Yeah, I think Atmika summarized it very well. I would just say that this becomes the multifaceted issue with stress playing a role, with resource constraints playing a role. And all of this requires us to have a single direction of solution. And we agree that a national law to regulate protection of healthcare spaces is exactly the way to go.
How does this generally play out? Is it a whole? I know that statistics show us that a majority of the violence is perpetrated by by relatives or families of patients. Is it that a large group comes in and then the violence and the situation escalates into violence? Is that how it normally plays out?
So Veda, I mean, give me an opportunity to correct you here. So there isn't really reliable data that says that the violence, like whatever violence that exists, has all been perpetrated by the patient and so it's very difficult for us to come to that conclusion. Importantly, why? Because there is a reporting issue here. So if there is a violence that's happening on patients, we've observed that there is skewed reporting that's happening. So although, as you said, yes, it's definitely an issue. Violence in healthcare settings that are mostly reported, and what the research shows is that it's mostly relatives led or caregivers led or patient led. But that again puts this in a very victim perpetrator context. And there's enough research that shows that when we buy out of that narrative, opinion rather, your solutions are much better.
Uma, would you like to respond?
I'll bring back the first point that Atmika had mentioned. We do not have any surveillance system at the national level, so most of the data collection that happens in current research perspective is self-collected, mostly through newspaper reviews, etc. And a large study done by Insecurity Insight, it is an international organization that works on collating such data, showed that there were only 5 attacks between the years 2020 to 2022. which does not exactly sync with the incidents that we've observed in real life. So the surveillance plays a very important role because unless we know the number, unless we understand what problems we have, we cannot come to an accurate solution.
Talk to us a little bit about what happens post such violent incidents. We know, as you told us, that the law often is not very well implemented, which means many times cases are not booked, and even if they are, conviction rates are really low. What kind of psychological impacts does it have on healthcare professionals, and also what does this mean in terms of perhaps healthcare professionals not wanting to work in what they see as unsafe settings?
That's actually that's a very pertinent question, Zabeda. So there is like strong evidence that suggests that violence can have profound psychological impacts on healthcare workers when they face it. So that evidence is there, and obviously, any violent event leads to a justified distress among the fraternity that's impacted. So, an outburst is a very, very common phenomenon that is noticed. And this is not just in India. We see this across countries that face violence. But the onus to solve this is not on the fraternity, but on the government functionaries. So, for example, when we talk about the Kolkata case and the strike and what that has eventually led to, that means the hospital OPDs were not functioning, patients were not receiving care, and justifiably so. So, doctors were out there, there was an outburst, they were out there fighting for the fraternity, and which has impacted the healthcare system further. So you imagine an already fragile healthcare system, a high stress healthcare system. And when an event such like this happens and then there is an outburst, it's just only further weakening a weak healthcare system, a fragile healthcare system. So the primary responsibility are people who should make stronger legislations and policies. And there should be absolutely zero tolerance in the community for violence in healthcare settings. So I strongly believe that it is everybody's moral responsibility to condemn any kind of violence in healthcare settings.
Uma, would you like to add to that, telling me a little bit more about the psychological impacts on healthcare professionals?
I think Atmika summarized it very well. It is an extremely vicious cycle because any distress added to the existing stress of practice can be extremely dysfunctional to the system. And we've seen that the system is already fragile. It is already functioning with everything stretched. And a lack of even a single healthcare provider seems to have a really big impact when we see it at the micro level.
Is there any research to show that this leads to problems with, say, hiring doctors for rural healthcare service?
So at the moment, there is no evidence that suggests that violence has had a direct impact on doctors not wanting to go to rural areas as such. But the threat is true anywhere, Zubeda, to be very honest. So the research right now, it doesn't suggest that there are only like this is only happening in say remote areas or isolated areas. That's not true. It's happening everywhere, and so somewhere it. I mean. As a researcher, I know. I mean, I mean, the researcher in me wants to question this, but it could certainly be one of the factors. So the fear and the threat is there. I mean, it's not easy to, read the news and say, I'm going to be a doctor in a very difficult area and do this. And so that obviously has an effect and an impact on everyone. But not just a doctor, like for that matter, a nurse for that matter. So immediately following the Kolkata incident, we had the rape of a nursing officer. So the fear is it's going to be prevalent everywhere. So that would impact a person wanting to take up a job. So that's always going to be there, Zubeda. Yeah.
Let's talk a little bit about, y'all were telling me about solutions in terms of increasing the healthcare spending in order to strengthen the system. What else? A central legislation increasing the healthcare spending, but what else? What else to say build back that trust?
Oma, would you like to take this one?
Yes, absolutely. So at ASAR, we've actually been addressing this issue for about 4 years. And throughout this journey, we started with exploring how violence occurs and have been able to actually start digging into why it occurs. We think that the violence that exists in the healthcare setting is actually a reflection of the broader societal issue, which is exacerbated by the high stress, exacerbated by resource constraints, etc. So every hit has a very high impact. To address this as a singular entity, we think the best way forward to would be to not have any separation between what we think is protection for a healthcare worker, what is a protection for patients. Usually, interpersonal violence exists between these two parties because there is some level of dissatisfaction that is not direct, that is systemic. So it is essential for us to protect the healthcare space as a singular unit. It is essential for us to invest in the healthcare space as a singular unit. These are places of healing and require protection for everyone in it. We go back to the international humanitarian law here and mention that even in conflicts, when all of these parties, all of them have to be safe, all of them need to be protected, it is essential that we start doing this in the general context. And this might be able to build back the trust between the patient and the provider, between the provider and the government, between the entire chain of different parties that are involved.
That segues nicely into my last question, which is the violence perpetrated upon patients by the system. How much more do we need to invest in patient rights and patient protection?
I do want to circle back, Zubeda, if I can, to what more can be done. I think you asked that, right? You asked what more could be done. So at this level, as Omar rightly said, that the interpersonal violence that has been witnessed in the Indian healthcare is obviously mirroring what we see in the larger society. It's 100% true. So there was a study done in 2014 where it was found that there are 4.8 practicing doctors per 100,000 population available in India. That is interesting. So keep this number in mind, what I just said. The proportion of budget allocated to health has reduced from 2.4% in 2018-19 to 1.9% in 23-24 against the promise of spending 2.5% of the GDP. So you can imagine the kind of pressure this exerts on the health system and how much this can impact healthcare delivery with everything that we're learning today. Not, I mean, I think just that the nation's taken cognizance today because of what happened in Kolkata, but this has been a very long drawn growing problem. But you can imagine what this can do, what having low budget can do to a healthcare system like ours, where we need to strengthen it. So on the government's website, there is this recent ratio of the doctor-patient ratio of which says it is 1:834, and the nurse-patient ratio is 1:476, which is an improvement. Yes, it is an improvement. There is no denying that, and it is to say higher than the standard of 1:1,000 doctors. But they've calculated this based on the number of registrations that have happened with the government bodies or the health bodies. But if we further look at this into, say, sanctioned post and in position doctors through the rural health statistics data, the picture is going to look very, very different. So it's very important that we obviously a legislation is required, but an overall investment in health is what we should be looking at very seriously.
Uma, would you like to add anything? I found it interesting that you said that the entire healthcare system, the space has to be protected. So everybody in it, including the patient, the provider, and all the ancillary staff that goes with it. Do we have anything like that at present that protects the patient also?
In India, not particularly, but there are countries which do that. I previously mentioned China and Taiwan having central regulations for regulation of health as an entity. Both these laws have very direct clauses to protect both parties, patients separately, and addresses violence against healthcare workers separately. And these can be used as precedents because despite the differences in the structure of the government and the problems faced within the country, the fact that South Asia has extremely similar situations, and there have been a lot of research papers that have been published about the macro level issue in the entire continent. It's very necessary for us to learn from success stories. If I'm not wrong, Taiwan has shown a very significant reduction in the number of incidents. And according to the report published by Insecurity Insight, there was only one incident reported in about 5 years between 2017 to 2022, which is commendable. Even if these laws are not perfect, they are still one step ahead in managing the situation and ensuring a better healthcare system for the country.
Thank you so much for speaking to us today, Atmika and Uma.
Thanks, Zubeda. Thanks for having us.
Thank you.
In Focus will be back soon with analysis of the biggest news issues. In the meantime, you can find our podcast on Spotify, Apple Podcasts, Stitcher, and other platforms. Just search for In Focus by The Hindu. We'll see you soon.